As adults, we all understand that we may develop conditions of the eye over time. But what about small children or even babies? Today we're going to discuss the eye care health of adolescent patients as well as adult strabismus with pediatric ophthalmologist Dr. Rupa Wong. Dr. Wong?
I want to talk to you.
Not now, later.
No, now.
All right, thanks everybody for being here. Today our guest is going to be Dr. Rupa Wong, who is the managing director at the Honolulu Eye Clinic. Dr. Wong, thank you for being with us.
Thanks for having me.
So we always like to start out with just a simple introduction. So why don't you give us an introduction about yourself and your background?
Sure. I'm originally from North Carolina. I went there for college at Duke. Really, it's a beautiful place to grow up. My parents still live there, but I was itching to get out of there a little bit just to spread my wings. And New York City just held such a thrall for me. So I went to medical school at Cornell and finished my residency at NYU, which is where I met my husband, who is a local boy from Hawaii. Many generations, his family immigrated here in the 1800s. I did my fellowship at Boston Children's in Pediatric Ophthalmology and Strabismus. I waited a year for him to finish his fellowship. I actually was on faculty for a year and had my dream job at Boston Children's Hospital in their Department of Ophthalmology. It was just really great. I was in charge of the residents. Really wonderful position, amazing chairman, great department. But my husband was very unhappy in the cold of Boston. So we made the decision to move out to Hawaii and open up a practice together.
I would imagine that the climate is quite different between Boston and Hawaii.
Very much so. And even though, he had done residency in New York and he went to Brown for undergrad, but I think being an adult, like a true adult, and having to dig your dig your car out of the snow and go to clinics. And he was working at ophthalmic consultants in Boston for his fellowship, Tufts OCB. So, he's driving all over the place. And Boston winters are rough.
Well, I can tell you, it's not something we experience in Houston, mind you, but I have been in Boston in the winter and I can understand what he's talking about. So I'm interested in what pediatric ophthalmology is. So we've got children here. It seems like their eyes are brand new. What could possibly be wrong?
Actually, a lot can be wrong. I am one of the treating ophthalmologists that's on the retinopathy of prematurity rotation. So we go and screen all the premature babies that are at risk for developing retinopathy of prematurity, which can eventually lead to retinal detachments if not treated at the appropriate time. So typically that's either handled by a peds ophthalmologist or a retina specialist. So I can do the laser treatment as well. I've seen, blocked tear ducts. We've got pediatric cataracts some babies are born with. And then of course, strabismus or misalignment of the eyes. The fellowship training is dual in pediatric ophthalmology as well as adult strabismus. So even though my practice sees about 80% is pediatric patients, and some are just simple glasses checks or that kind of thing, I'd say about 80% of my surgeries are adult strabismus surgeries because I've grown a reputation of being able to handle the difficult to treat thyroid cases or the stroke patients with adult strabismus.
So could we expand on the retinopathy subject a little bit? Could just explain a little bit about what that is?
So babies that are born younger than 31 weeks of gestational age, so that's about, earlier than 2 months premature and less than 1,500 grams are at risk for developing retinopathy of prematurity. And what that is basically your baby's retinas are not fully formed until they're born at 40 weeks gestational age. So if they're born premature, the retinal blood vessels aren't fully grown. And they can grow then abnormally. They can grow where they're leaky and they're causing bleeding and eventually, worst case scenario, retinal detachment. So any of those babies that meet that threshold criteria, then there's very strict protocol that we follow as to when we examine them and we are assessing the retina, how much of it has vascularized. And we keep following them until it's a fully mature retina.
So how are you diagnosing cases like that? And specifically, I would imagine that dealing with pediatric patients might be a little bit different than the way that you would deal with adults. So how does that work with children in doing the actual diagnosis for a disorder such as that?
Two things. So there's almost two different subsets of populations. With the premature babies, they're in the neonatal intensive care unit. I have an ROP nurse. they're swaddling the baby, they're holding the baby, we put a lid speculum in. I'm doing a very complete and thorough exam, more complete than probably we would ever do on an adult in a office, because we're really able to do everything and visualize the retina, because the baby is so small and we can just fold them down. Now, that's contrasted very much with the 2-year-old that comes into my office. And first, I have to be quick. I know how to glean the most important parts of the examination really within a 20-second or a 30-second window. You have to have props. You gotta have a lot of things that are going to distract kids. I have the DVD, the system in the background that shows the movies. I've got lots of toys that are fun. I have a very upbeat and entertaining personality that I really just put on 100%. You have to employ all of those techniques to be able to garner their attention, make them feel that they're not being threatened, because especially right now, it's hard. We're wearing masks, I'm wearing gloves that I don't usually do. I usually put stickers on my nose. I can't do a lot of the things that make funny faces. I can't do any of those things in my office anymore. So you just have to rely on what you can. But first and foremost is being quick.
Right, I can imagine. Well, I have a couple kids of my own, so I can appreciate that. Anything you want to do, you got about a 5-minute window to get this done.
Exactly. And but the nice thing is with ophthalmology, so much of it is we can directly visualize it. So yes, I can get a history from the parent, but I am also, since I have 3 children, I'm really good at, as your wife I'm sure is as well, at multitasking. So a kid can be talking to me, or the parent's talking to me, giving me the history as I'm doing the examination, and I'm cataloging everything, and I save it all and put it all in the chart later. Because that's just what you have to do. You can't be step by step in peds. You want to get all parts of the exam in, but you've got to be able to do it in a really complete manner, but also time efficient.
Absolutely. So if we've diagnosed a situation where we're talking about retinopathy, how do you treat that, and what's the process look like? And as you said, most of these you're dealing with premature babies. Is this something that you deal with in older children as well? And if so, how are you treating it?
So for retinopathy prematurity, we typically treat frontline as laser treatment. There's also injections of anti-VEGF that you can do, and it's very, very strict criteria. So once you see the blood vessels acting in a certain way, you see stage 3. There's different stages and zones. And then in my hospital setting, there's 4 of us, and we will often get a second opinion. So from one of the other 3 pediatric ophthalmologists, or there's 1 retina specialist. If I think that a baby needs to be treated, I will ask for one of them to also come in and give a secondary concurring opinion, because this is serious stuff. We have to treat them within 72 hours of diagnosis, because studies have shown that earlier treatment, once they have reached that stage of requiring treatment, that's going to lead to a better visual outcome. So it's typically laser treatment, just like for a diabetic patient, but we bring them to the operating room. There's an anesthesiologist, they put them to sleep, and then we do 1,500 bursts of laser energy in each eye to slow that progression of the abnormal blood vessels. And though I don't do it, but a lot of people do the injections as well, the anti-VEGF injections once they reach a certain point also.
So another thing you mentioned a moment ago was about blocked tear ducts. You were saying that that's something else that you treat often. So what are blocked tear ducts in this context, and how are you treating that?
So it's interesting. All 3 of my children had a blocked tear duct. And what a blocked tear duct is, it's something that typically opens up. There's an extra little membrane in the nose, and 5% of newborns have this, and usually that little membrane opens up on its own. We can help it along by doing something called Kreigler massage, and my video on that on YouTube for some reason has a lot of views, even though it's very simple. I just demonstrate how to effectively perform that massage on your child, and I'm doing it on my son. We don't intervene surgically until babies are past the age of 12 months, because 95% of the time it's going to spontaneously improve, or improve with just the massage itself. So we don't really do anything unless the babies are outside of that age window. And if they do require treatment, what we're doing is probing. We insert little metal instruments into the canalway through the tear duct system, and we punch open the opening. And then I also will do a balloon. Think of it like a balloon catheter for your heart. We do a little balloon to open up the passageway and smush everything out. And that way I don't have to leave a stent in place, because the stents have to be removed.
So if I'm a parent and I've got a newborn at home, is there something that I should be looking out for? And when should I be concerned, or should I be concerned at all?
So blocked tear ducts usually present with crusting discharge, a lot of tearing. Sometimes the eye is swollen shut. And it's not a true infection, though that's what it seems like. It's more, think of it like a pool that with stagnant water and moss on top of it. So the bacteria are there, but they're just inhibiting the top layer of the tear film. So, doing the appropriate massage, it really helps 3 times a day. You can also cover with an antibiotic drop as well, just to get the bacteria contamination to decrease. And there are even some studies about breast milk in the eye with the immunoglobulins to help just resolve the crusting and the discharge. So I will, though it's not quite on-label use, breast milk, I will recommend that as well.
Absolutely. So just in general terms, so we've talked about some disorders that we're dealing with, some sort of more severe cases that we're dealing with. So what does a typical patient look like for a pediatric ophthalmologist?
So mine is really a mix. I will sometimes just see the 6-year-old who failed the vision screen at their pediatrician's office, or I am seeing a an adult patient who has a brain tumor and a cranial nerve palsy with resulting strabismus. So I get that mix, which is why I love it. And I think it's so interesting because I'm diagnosing on one hand, really complicated things relating to neuro-ophthalmology and strabismus. And then on the other hand, sometimes it's very simple, just giving a child a pair of glasses, but that can also, both are very life-changing. So my typical day just really runs the gamut between those. Allergies, amblyopia treatment, which is patching treatment, a lot of that we do as well. So, yeah.
So let's talk a little bit about strabismus. We've mentioned that a couple times here. I think you gave a brief description about it, but can you talk a little bit more about what is strabismus? And obviously you're dealing with it with children and adults. So what is that, and how are we dealing with it?
So strabismus is misalignment of your eyes. The eyes can cross in, which is called esotropia. They can wander out, which is called exotropia. They can even be vertically misaligned. And the causes for it are a little bit different in children versus adults. In children, sometimes it can be related to their farsightedness or their nearsightedness. Sometimes it might be related to an injury in their eye. So there's all different reasons for having strabismus. In adults, it can be related to thyroid disease, diabetes, or just the fact that they had it when they were young and for whatever reason, their control over it has decompensated. So a big range of explanations for it, and that then details how we're going to approach the management. If the child's eyes are crossing in because they're farsighted, then we give a pair of glasses. And so we go through this stepwise kind of algorithm to figure it out before getting to the surgical point.
Absolutely. So when we're doing a surgery, if we were going to do a surgery on a strabismus, what exactly is it that we're doing?
So what we're doing is, and this is one of those surgeries that honestly has not changed all that much in 50 or 60 years, LASIK and refractive cataract surgery, we've got all of that. And everybody always asks me if I'm doing this surgery with lasers. I'm not doing this surgery with lasers. I'm doing it with good old fashioned scissors and forceps and knives and that kind of thing. So there's 6 eye muscles that move the eye around, 2 that move it horizontally, 2 that move it vertically, and 2 that twist the eye. So depending on the examination in the office, I've decided on a surgical plan, which eye muscles I'm weakening, which eye muscles I'm strengthening to be able to realign the eye. And the best way to get to the eye muscles is you can make a little incision in the white part of your eye, in the conjunctiva, and I do the kind of incision that the eyelid should be able to cover so that you really don't have much scarring after the surgery. And then we use a series of hooks to bring the muscle up. We hook the muscle, cut it, and either move it back a few millimeters based on tables and charts, like loosening a belt buckle, or we cut a piece of the muscle out and we yank it forward, like tightening a belt buckle. And what I do, since I trained at Boston Children's with Dr. David Hunter, he does a lot of adjustable suture surgery, which is allowing for fine tuning of the surgery in the recovery room when the patient's awake, because this surgery is done under general anesthesia, unlike a lot of the other eye surgeries. So it's totally general anesthesia. So I don't really know, have I relieved the patient's double vision? Are the eyes straight? I'm doing everything based on my tables. When they wake up, anywhere from a teenage patient to adulthood. I don't do the adjustable for children, but I've done even, 11 or 12-year-olds quite successfully in the recovery room. They're awake for that. And I use a little slip knot and I pull the muscle if I've over or under corrected it to make it as perfect as possible.
So if I'm understanding correctly, as you said, sometimes you're removing a muscle, but a lot of times it's moving a muscle from where it's attached now to a new place. Is that what it is?
Yeah, yeah, that's exactly. And it's amazing.
Yeah, that is intriguing to me. So you and it makes a lot of sense. So you've got a muscle here that might be a little bit too tight. So we're gonna loosen that and we're gonna move it back a little bit over here. And when you're
Yeah.
talking about the sutures, maybe you want to trim that back a millimeter back the other way. So you're doing that after the fact.
Yeah, exactly. Because the before adjustable sutures, and not everyone does adjustable suture surgery, but they would just tie it down in a permanent knot. And then if you woke up and like, I still got a little double vision, well, we might have to take you back to the OR. But now with this, with this slip knot, which I think is adjustable suture surgery has probably been around for about 20 to 30 years now. David Guyton was a big proponent of them over at Hopkins. And then we can actually fine tune it. We have, something in our wheelhouse to try to get the most precise measurements possible. And this is really important for adult patients because most of them, if they have developed strabismus later in life, they see double. So they're seeing two of an image. Where versus children, if they have strabismus, they never see double because their brain shuts off the eye that's crossing. So to avoid that, it's called suppression, to avoid that double vision. So I have to really be spot on with my adult patients because even if it's close but not perfect, that's going to drive them crazy. So having the adjustable technique is really beneficial for that.
So it's something you touched on a second ago. If the child's brain is going to shut off one eye, as you said, which makes sense. When you correct this, does it come back? And how long does that take?
So correcting the alignment of the eye is just one step. So if they have poor vision in that eye and it sets up this cycle. So I have a lot of kids, maybe, the eye crosses in, that causes the vision to become bad in that eye. And then it makes the eye cross in more and it sets up that cycle. So we uncross the eye, or typically first what I'll do is start a little bit of patching treatment because I want to start developing those nerve connections very well and strengthening them between the weaker eye that's crossing and the brain. And then we'll do the surgery. And then really it's about doing that patching treatment. It really falls upon the parents because I can do a perfect surgery, but if the vision is still bad and the parents are not patching or the child is not patching, then the eye may just return back to a crossed-in position.
So explain patching. What do you mean by patching?
So patching is, and I actually had a patch around here because I did a little video on it before, but you've seen those kids that wear a patch on one eye. That's for a condition called amblyopia. And there's a couple different reasons for having amblyopia. Some people call it lazy eye, but it's not quite an accurate term because you might have an amblyopic eye and the eyes are perfectly straight. It could just be because the child needs glasses and is really nearsighted in one side and really farsighted in the other. This farsighted eye might become amblyopic because this eye is clear, or this eye has no vision problems at all. The eye that has vision problems becomes more problematic and the brain just shuts it off. So that's one reason. Sometimes it's the crossing, or sometimes it might be a lid droop or a cataract. So anything that is hindering the growth of the optic nerve connections from the eyeball to the occiput where the vision centers are. And that all happens during a critical period in a child's development, which is all the way up until about age 13, studies have found. So patching treatment it's not really that effective in teenage years or in adulthood. You're not really going to boost the vision. The amazing thing is when you put a patch on, just like working at a muscle that is, that's atrophic, you make that optic nerve stronger and you increase the amount of optic nerve radiations to the back of the eyeball. So you can improve the vision by just wearing a patch. So we have all these different regimens, and based on how they're improving or if they're not improving, that's what patching treatment is.
That's very interesting. And I think as you said, I think we've all seen this before, and it's always been in younger children. And so what we're talking about here is you're patching the good eye, right? To force the brain to look. It's like we're not going to be lazy. We're going to get this one up to speed, right?
I tell most of the kids it's like an exercise for their eye. They're working out that bad eye so it can see better. They're making it stronger.
Well, Dr. Wong, I really enjoyed our talk today. I think we covered a lot of interesting topics. We'd love to have you on the show again sometime, but I really think this is very interesting. There's a lot of things that I think children deal with, and like this patching thing that we've seen a lot of times, or it's good to know how we're actually treating those. So, if you were to talk to a parent today that didn't know that these issues exist, is there any advice that you want to give to parents about certain things to look out for, or things that they might need to be concerned about?
Well, first, I mean, especially now, a lot of kids are distance learning. The kids are at home, so you can watch how they are interacting with their learning material, if they're squinting, if they're adopting kind of different funny head postures. That can be it as well. My middle son has strabismus intermittent. He squints a lot in the sunlight, or even when he's tired, they might notice the eye wandering. But first and foremost, just making sure to keep those annual exams with your pediatrician, because the pediatrician should be checking the vision, right, every year at the annual exam. And that's really what we want to drive home, is that the pediatrician should be that center. And then hopefully they're checking the vision. If there's any issues, that they will then refer appropriately.
Absolutely. Dr. Wong, thank you very much. So for everybody, take that home. Make sure that your pediatrician is checking your eyes every time that you go for your annual visit. And hopefully, if there's any issues, we can get it to a pediatric ophthalmologist to get it taken care of. Dr. Wong, thank you so much for being with us.
My pleasure. Thanks for having me.